Dear colleagues, welcome to our monthly dialogue. You remember that our dialogues are live streamed in X and then they're posted in YouTube. You can find them easily. Go please to our website, the website of the European Air Journal, and you will find the tile dialogues. Click there and you will find these and previous dialogues. Today is a very important dialogue. I have a double honor today. The first honor is to have as a guest one of the most famous cardiologists in the history of cardiovascular medicine. She has been among the founders of the adult congenital heart disease. And this specialty of cardiovascular medicine is becoming incredibly important also because of the prevalence. For the first time, the number of adults with congenital heart disease is higher than the number of children with congenital heart disease. And this is really a signal of how successful has been this specialty of cardiovascular medicine. And today we have one of the founders of this important discipline, a true legend in the history of cardiovascular medicine. So my first honor is to guest Jane Somerville, and the title of our dialogue will be Past and Present of Congenital Heart Disease, narrated by Jane Somerville, one of the protagonists of this important field. But I also have a second honor today, and the second honor is that the co-host for Jane Somerville is John Deanfield. You know him very well. He's not only a top scientist, but we also had a very, very interesting dialogue with him. I co-hosted this dialogue with Peter Libby, really a fascinating story. And again, if you're curious, you can find this previous dialogue in YouTube. And now, John, please introduce our legend today.
Well, thank you, Filippo, and it's a great pleasure to be here and introduce Jane Somerville, who's been a friend and colleague for longer than I care to admit. So Jane, as you've already said, is really a pioneer in adult congenital heart disease. Her work really shaped the specialty as we know it today, taking it from one of the smallest orphan areas of cardiology to being central to the way in which we manage patients in clinical practice today. She established one of the world's first dedicated adult congenital heart disease units. That was at the National Heart Hospital in the UK. And she coined the term GUCH, grown-up congenital heart disease, to describe the increasing number of survivors. Her many contributions are really recognized around the world. And what we're going to do today is to explore a little bit about her career that really has transformed the care of this unique group of patients. So Jane, you're a very famous cardiologist, but you initially planned to be a cardiac surgeon. Can you tell us a little bit about what made you change your direction early in your career?
Well, yes. Firstly, I'd like to say I'm deeply honored, Filippo, to be here and with my friend John Deanfield. And I don't feel at all famous, but I'm delighted it to be said around the world. Thank you very much. I feel much better for that honor. Now, in answer your first question, yes, I desperately wanted to be a cardiac surgeon. And the reasons that I left it, although I stayed on an extra 6 months because it was the most exciting thing that ever happened to me in my career, but I recognized I was clumsy, that my hands were not exactly attached to my brain, if I had one, but I realized they weren't generally functional. The second thing was that I really don't think I had the physical stamina for all night and all day and going back for bleeding and not getting it right and the diagnosis wrong. And we had this horrible bubble oxygenated invented by Lilly High, which I didn't think looked after the patients or perfused them enough. It was a nightmare. But perhaps the most important, having come to those basic conclusions about myself, was that I'd seen a man I fancied. And I didn't quite see how all this excitement by night and all day and never thinking about anything else but cardiac surgery that I didn't have the talent for was quite going to catch the man I fancied. So that's the answer. But I have to say, to anybody who wants, cardiologist who wants to spend 6 months well spent and well taught that really teaches you anatomy, it made me a very different cardiologist and registrar from all those I was competing with. I knew things they had no concept of and that were fundamental. And I think it held me in very good stead. Even Paul Wood respected what I said because I knew the anatomy inside out. So I don't think it's a waste of time. And I think lots of these people that look on images might also do well to spend 6 months inside the heart with the cardiac surgeons.
So that leads to a really important follow-up question. You've, over your career, worked with some fantastic people, and you've made some incredibly important advances. Tell us what the most exciting things you did early on in your career that really has changed the way in which we manage patients. What was the sort of headline developments that you were involved in?
Just let me get there, please, while I think. One thing I learned was that you must only work with a very good cardiac surgeon. And this taught me that they had a certain way of expressing themselves that I didn't think was entirely truthful. And they were very courageous with other people's lives. And I thought that I must only ever work with someone who is really good. Now, I was lucky enough, fortune was kind to me, or else I just was lucky, and I was with Magda Yakub. I was with Donald Ross, who was the senior registrar at the time. By the way, when I was in training with Sir Russell Brock, he didn't address any question to me. So how would you like this, girls? You'd be grumbling all the time about being prejudiced against. Well, he didn't speak to me at all. He addressed Donald Ross if he wanted to know why I wore earrings in his operating theatre, or I hadn't got my surgical boots on. Can you imagine not being spoken to by your boss? You wouldn't put up with it 10 seconds. Anyhow, it was all quite fun. In answer to John Deanfield's question, I was very fortunate to be associated with very good surgeons. I think the most exciting first innovation that I faced up to was the aortic homograft. When Donald was decalcifying an aortic valve, good treatment for aortic stenosis, but the aortic valve ran down the sucker and we were left without a valve to put in. And Donald remembered that he'd sterilized at the request of Lord Brock a valve, and he had it sterilized in a pot over the sink in the dog lab, and that was sent for, reconstituted, and put in the patient, and worked. And that was the beginning of the aortic homograft used in the aortic position. And then I was closely associated with the 66, we reported homograft in the right ventricular outflow tract for pulmonary atresia, which completely revolutionized right ventricular disease, congenital and pulmonary atresia, and was a very successful operation. And that poor boy, Stephen, has only died in the last 5 years. And this, we're talking about surgery in 1966, 65. So that was very exciting. And then we had a lot of excitement. Francis Fontaine did his operations, which, as you know, have been much modified and were modified by Donald and Billy Kreutzer. And I had a lot to do with those early cases. And then Ross operation that everybody speaks about, the most remarkable cure, almost, not quite, for aortic valve stenosis, surgical, by far the best valve. And Donald had thought it out. And it was the reason why he did the first homograft in the RVO right ventricular tract. It's not realized. That was not a casual invention. He'd already thought out that he was going to take the pulmonary valve out and put it in the aortic, but what was he going to put in the right side? And that's why he did the first operation. He'd already worked out what he did and was reported in 1968. And then, of course, I was closely associated with the first cardiac transplant in UK because Chris Barnard was Donald's very close associate from Cape Town, and he would come over and we were able to do the first cardiac transplant, and I was invited to be the physician to it. The fact that, in fact, he died of a medical complication has always made me feel bad that I wasn't as good a physician as I should have been. And I thought I was good enough. I was like the surgeon's handmaiden. But in fact, the first cardiac transplant in the UK, sweet man, transformed his life, but only for 6 weeks, because he died of thromboembolic pulmonary hypertension, not of rejection, with which we were obsessed and spoke about twice daily. And then I witnessed many, I was not part of, unfortunately. I remember when Mustard did his operation for transposition. It was extraordinary from Toronto. And when Rashkind, who was a great guy, Bill Rashkind, great fun, paediatric cardiologist, did his balloon septostomy. So I saw all those things. I saw the development of paediatric cardiology. It wasn't there when I had first qualified and when I was first into all this, and boy, did we need somebody. So it was undoubtedly a right development, which mainly took place in the States, I think. I saw the development of prostaglandin, which made a huge difference. I saw the development and became very close to Aldo Castaneda, as he said rightly, and managed to make it work, operating on patients as early as you can, neonates and infants, rather than waiting for what you thought. I think that was a great development. And making newborn surgery work in the Boston Children's, they absolutely held sway over the pediatric cardiac fraternity for 25 years, would you say, John? Long time. With those, anyway, I answer your, we've come to the 70s, really. More or less, I've told you what you want to know.
So those were events, huge events led by pioneers. But at those days, we didn't have the sort of imaging and the testing that we have today. And some of our younger colleagues are sort of shocked about the way in which we managed patients in those times, where we didn't have not only the testing we have today, but didn't have the background outcome evidence to support some of the decisions. How did you make decisions in those days, and how did the clinical practice develop in that era?
I think you make a good point, but I think our younger colleagues have to know we were good clinicians, and most of them not, by the look of them. So we were good at clinical cardiology. We had to be. We were trained in a hard school. John, you were trained in a hard school, and I was trained in a very hard school. So that was one thing. We had 4 things. We had our clinical ability, which took place, which was very important. We had cardiac catheterization, and as it got better, not we, I didn't get better at doing infants and newborns, plus angiography became better and more refined and in 2 planes. That was good, we could look at. And we had a chest X-ray and an electrocardiogram, pre-echo, pre-other imaging. But usually, depending on the intensity of investigation, which was very big in Great Ormond Street, patients more or less went to surgery with the right diagnosis, which was rule one. I think a bit less so in guys. I can remember Brock saying, oh, groaning all the time, that they're so careless. They're so careless. I have to know whether I'm confronted by a boy on a bicycle or a tank division. And I thought, that's a very funny analogy, but anyhow, I've remembered it all my life. But really, it does make a difference. So they went to surgery with the right diagnosis, and then the question is, was it the right decision? Well, we were led by the surgeons, I do think, and the surgeons got to read the books, what little was known, and they know that patients develop pulmonary vascular disease if left with big septal defects, and there was no cure for pulmonary hypertension. They got left with chronic heart failure and died with big lesions. They might fail with narrow valves, so it questioned on severity. And then there was a whole group of asymptomatic moderate lesions that I think we didn't need to rush into, but they were only too keen to do something about. We were led by the surgeons, actually, and the pathologists to a certain degree. And our knowledge increased, and we got to learn over the next 2 decades what was dangerous and what was not. And I think we fed our knowledge in, and then meeting and talking and sharing was incredibly important then. And I think that was something good and helped.
So I remember that very well, that it was the dialogue between the physician, the surgeon, and actually the anatomists and the pathologists that really helped shape the way in which we understood conditions and the way in which we managed them better going forward. It was very exciting. I used to call it Star Trek medicine, because we boldly go where no man had been before, and it felt like that sometimes. But it was all based on very good clinical science and very good follow-up and collegiate decision-making. I must say that was one of the things that attracted me to the congenital heart disease treatment, the way in which there was teamwork, and every case taught us about the next case management.
It really was very exciting, and sharing was very exciting, I think. And I was very glad you asked me kindly what I'd been associated with that was possibly important. I think I was associated in the subsequent decades because of pathologists. I was always searching for pathologists because we had rather awkward situation in the heart hospital over pathology. So I had to look elsewhere because I was obsessed with where the hole was and what it did and what it looked like. Nobody else was. So I had to have pathology friends. And I had 2 friends, Anton Becker from Holland and Louis Becou from Argentina. And with them and with my constant discussions and about anatomy and pathology, both of them clinically minded pathologists, they came on ward rounds. They were interested in the living as well as their necropsies, which is rare in a pathologist, I can tell you. But I managed to do 2 things. One is it was clear to me as a clinician there was much more disease than the disorder of structure in congenital heart disease, which my colleagues felt obsessed by. In fact, I was not entirely acceptable to the Paediatric Cardiology group. Not sure John was either, by the way. We who were trained in adult disease, he was politer than I was, but they were impolite about me. I was cast out. So whatever I said, you didn't listen to, but it doesn't matter. It makes you strong. Anyway, the concept of congenital cardiovascular disease, that in these hearts, just as in these babies there are other abnormalities, in these hearts there are other abnormalities you don't see. Bad myocardium, bad endocardium, bad blood vessels. They are born with sometimes. It's congenital cardiovascular disease, not just disorder of structure and transposition. And that will influence the long term. So I was very operative in that from the clinical and pathology correlation point of view. That was very important. And the other thing that I became obsessed with and was lucky enough by chance to be asked to give uh, St. Charles lecture on the subject was change in form and function, realizing that the heart in the baby, which looks all pristine and pink and lovely, is not the heart 10 years later, 20 years later, or 50 years later. That a change in form with function goes on through life. And what's written in the books about what is a VSD may not be the VSD you're looking at. Or what fallow looks like. It's not fallow age 20. It's not fallow age neonate. So I became obsessed by this and the correlation of change in form and function in congenital heart disease, making it to me a moving disease, not a static disease like we were reading in our books. And I think that was very important. Well, it was important to me, even if people laughed. In fact, it's better if they laugh because you know you're right then. That was my view. You can laugh. Doesn't matter. Like congenital cardiovascular disease. And it was very important to have good pathology. And both those helped me.
So this was a time, Jane, of rapid clinical learning and change, but you did something really important. At one point, you created a World Congress of Congenital Heart Disease, Paediatric Cardiology and Cardiac Surgery. You were the organizer of the first World Congress, which actually happened in London. And it really changed, I think, how we brought the speciality together, particularly cardiologists and surgeons, in a scientific and teaching manner. Tell us a bit about how that happened. That can't have been just chance. And what were the challenges that you encountered?
It happened. I'd just like to pay attention to the surgeons who really did influence my thinking very much so. In 1975, if we have to begin there, it does seem to some of you so long ago, but not so to me, there was the second Henry Ford Symposium where every cardiac surgeon worth his name and while was present in Detroit. Everyone. And they were going through everything. The only surgeon who was not present, and this just shows about meanness, was Lilly, who had actually invented the possibility, almost Nobel Prize winning, of making it possible to put a patient on bypass. And he was not invited, because he's a bit naughty or something, or I don't know what, I'm not getting into politics. He was the only person absent, which says something about human behavior. But anyhow, back to there. And there they discussed absolutely everything from a surgical point of view. I don't know why I was lucky enough to be there, but there were only 3 physicians. Nadas, who was rather patronizing, didn't want me speaking to his young surgical colleague. Well, that would be a waste of time. And Van Mierop, and little me, wearing very short dress, I think, I seem to remember. Anyhow, I was there because of the homograft, because I was obsessed with what happened to what surgeons did, so I knew. I was obsessed with follow-up, necropsy, pathology, and odd things. I didn't understand how any machine worked, but anyhow. And I felt that here were all these surgeons completely obsessed with their cleverness. And by the way, it's where Adib Chatain told the surgical world he had successfully switched for transposition. And it's the only time I've ever seen surgical colleagues, and they were there en masse. They rose to their feet and clapped for 5 minutes, as he could barely speak English, but he showed the slides of his successful switch operations in 1975. It was the most exciting moment. Anyhow, I digress. He'd got, I think, 6 cases successfully operated. And I came back thinking, we physicians have to assert ourselves. We have to share what we know because we are responsible for care and wrong diagnosis and recognition and blah, blah, blah. So why can't we have why can't we speak about ourselves? And I was scientific secretary of the European Society of Paediatric Cardiology at the time, and I spent my time trying to get sessions for us in the World Congresses. And they didn't want it. They only want to talk about coronary disease, a bit about arrhythmias. Well, you know the rest, what they want to talk about. Heart failure barely came in, but it did come in. Certainly, you might be sequestered in a tiny room at the end of a big Congress center, but you wouldn't get much hearing. And I was fed up with this and said so. I was lying in the bath, cross at a frustration. Yet another, we'd failed in Tokyo, and we'd failed in Switzerland, we'd failed somewhere else in world cardiology. And I thought the only thing we can do is have our own. We'll have our own conference. And I got out of the bath, told my husband, Walter, who has had a great, important influence on me in many good ways, and said, Walter, I've had an idea. I've had a wonderful idea. We should have a World Congress of Paediatric Cardiology. And Walter, whom John knew well, and it influenced John as well as me, Walter said, I wonder, would you mind drying yourself and not wetting my new carpet? That was the response I got, which was somewhat like trying to organize the World Congress.
So what did it do? It brought people together, and people should know that this Congress still runs. It runs more and more successfully. It has several thousand attendees now, and it really has changed the way in which training has been developed and delivered in congenital heart disease. It has nursing training, it has paramedical training, cardiologists, surgeons all together. And I think it has made a massive contribution to the development of the speciality.
Well, I think it has. I'm glad to hear you say it, because it was a labor of love over the next 5 years, but fun. And I knew my way around the world and who was who and what was what. Lots of surgeons were my friends, and we gave equal exposure to cardiac surgery and cardiac medicine. And we had, as the president, Jess Edwards, a pathologist, so there was no division there. And we were soon, I think the next time or the time after, to join with the surgeons. So it became the World Congress of Paediatric Cardiology and Cardiac Surgery, which I think was how it was meant to be anyway. And I think it did. It was remarkably difficult to get going. The Brits, my beloved colleagues, opposed it. The European paediatric cardiologists said that's not going to happen when I announced my idea. And I remember walking back in Ghent meeting and getting on the wrong train to miss my plane home because I took the one in the wrong direction. And but we managed, and we managed because of Canada. Dick Rowe, a great paediatric cardiologist, was there at the meeting of the European paediatric cardiologists. And he got up and he said, I'm surprised. Canada will be there, even if we have to close down paediatric cardiology. So, you know, that's a big country, very important in congenital heart disease. So I was ever grateful to my Canadian colleagues. And with Fergus McCartney and James Taylor at Great Ormond Street, who I did outpatients with once a week, they came together and they came on board, and Fergus was the scientific secretary. No, he was the Secretary General. He liked making the decisions, and James kept the treasury. We didn't have any money, but I said, we'll get some, don't worry, there'll be something to count, and off we went. So you can do these things if they're right, and that was right.
Thank you. So this is really a good segue into Filippo's question, I think, which is really about the greats that you've worked with. Filippo, over to you. You're on mute, Filippo.
Filippo, don't
Yes,
abandon John and I, else we'll go off and party.
Okay, no, well, really a fascinating story. And two short comments before asking you, Jane. The first is about the heart team. Now, in our guidelines, the heart team is class 1 recommendation. Now, if you need a recommendation from guidelines for the heart team, this means that perhaps this is not in our DNA yet, while you started long ago. I mean, you created in congenital heart disease for the first time strong heart teams. And we have shown us how important it is to discuss difficult cases in the heart team. And then we have to wait 30 years or more to have this class 1 recommendation in guidelines, while you made up this heart team long ago. You showed the way. A pity that the way you showed long time ago has not been picked up much earlier. And we had to wait for guidelines, class 1 recommendation in guidelines. So thank you, Jane, because this example you gave in congenital heart disease for the first time about the importance of the heart team should be really a strong inspiration for all our colleagues. The second comment is this impressive series of names: Fontan, Ross, Barnard, Raskin, Castaneda. It's a pity we cannot have dialogues with them, but I'm really grateful that you are bringing up these important names, because they really created the history of cardiovascular medicine. So thank you for reminding us their important contributions. And here I come to my question. So you've been working with these legendary figures in cardiology, but who is the most important, who really shaped your thinking? Number one, in your experience, the person who really inspired your profession and your career in medicine and in cardiology and in medicine in general. Among so many important colleagues, who is the number one for you?
Paul Wood.
Paul Wood.
Paul Wood, no question. Paul Wood shaped my thinking, taught me to diagnose, taught me how to be accurate and keep records, showed me that you have to, although I already fancied to do this, that it's very important to chart your mistakes. I probably know more about my mistakes and errors in medicine than I do about my triumphs. Perhaps I haven't been any, but occasionally one gets lucky. Without doubt, Paul Wood was the greatest cardiologist as a diagnostic and also good clinician. Tricky man, and followed by all sorts of people. I mean, you had to elbow your way in the clinic, and I was very fortunate to be one of his first assistants when he died. He died prematurely, as is known, from acute coronary. He died in Walter's arms, having told Walter that he must not be resuscitated or have his chest opened. I think about the third day he had his angina. Anyhow, so Paul Wood, extraordinary influence on my thinking, and very intolerant of carelessness. And I think I probably was intolerant anyway, but it served to increase it, I think, of sloppy diagnosis and sloppy clinical care. So I don't think that was necessarily a good aspect. Then Brock himself. Russell Brock was an extraordinary, accurate diagnostician and note keeper. And he had the most troublesome secretary, who, of course, took one look at a female house surgeon, and that was that. So those were not very easy days, but they were wonderful days because one was kept to be a careful clinician even though the whole surgical thing was like one long episode of MASH. I mean, it never stopped, and we didn't really know what we were doing, and the patients died, and it was appalling. But when you were accounting to Brock, you had to have your brain in order as to what had happened, why, and what you didn't know, and everything. You were taught to work out things from first principles. Those are the two that form my thinking.
Filippo, can I interject? I mean, I know there is someone that Jane would talk about who was probably the biggest influence on me as a cardiac surgeon, was Mark de Laval, who's a wonderful surgeon in the more recent era, but I think you worked with for a long time and had exceptional qualities as well, didn't he, Jane?
Exceptional qualities. I think I was a sort of formed bad character by the time I was able to work with Mark de Laval, and it was a very important experience, a very meticulous surgeon that I had never met before. But a very important person, huge contribution. And anyway, there's much that John and I could tell you, very important in pediatric cardiology and cardiac surgery.
And I mentioned him because, like you've been saying, you were always very meticulous and not only learning from your triumphs, but from failures. And Mark was the same, wasn't he? He reported his failures in a way that really advanced the subject and changed the way in which we think about risk and benefit, didn't he?
Well, coming back to Paul Hood, he was professor of cardiology at Hammersmith. And when with John we started at Hammersmith, his memory was still very, very vivid. But now, Jane, let's change topic. You've been in your life a strong advocate of women in cardiology. How difficult was in the old days to emerge in a men's world?
Well, first, let me say, I think it was difficult, but I enjoyed the challenge. And I had been to school with boys, so I thought men around me were not a lot different from the schoolboys I had known. And I needn't, so I was kind of used to this naughtiness that boys do and their plots in the bar. It was difficult. And I think the most difficult thing, although I didn't find it particularly difficult, was you weren't counted. When I went to Guy's, I was walking across the quad straight from school, and the senior physician appeared with his retinue. And he said, "Oh, Christ, not another bloody woman here." And all the boys behind, about 8 or 9 of them, tittered at me. I walked on. I fortunately was born with a turned-up nose, and it just turned it up more onto the medical school. But you were subjected to that sort of thing constantly. Not quite as bad as coming from the senior physician, but you can't. It took no notice. It didn't rubbed off on me. And there were 9% women in Guy's. And then the difficult thing was not really being counted. I remember applying for, I think there were 13 consultant posts and never even getting, sometimes no answer, sometimes certainly never on a short list. And this was hard to take because women really, we deserve to be considered. And although I was not an aggressive feminist, strangely enough, I felt very, very keenly that we should be judged as equals, equal intellects, or at least our CVs judged from anybody knowing what sex was the applicant. I felt that very keenly and have always worked for that and have always overprotected a woman. I think I understand men better than I understand women, so a little fearful of them, but I've always done my best for them because I thought I'd been very lucky. And I don't think we're perfect applicants for anything, but I think I think we should be judged justly, and merit is equal. I don't think merit necessarily has a gender.
Thank you, Jane. And coming to women, we have in the audience an important lady, a brilliant lady, Margherita Brida. Hi, Margherita.
Oh, hi. Hi, everyone. It's
Welcome.
wonderful to see you all.
Margherita, Margherita is editor for congenital heart disease for the European Heart Journal with Mike Gazzolis and David Sellermeyer, a wonderful team. And I'm grateful to them for their contribution to the success of the European Heart Journal. Margherita, you have in front of you this legend, Jane Somerville. Any question for her? Please, we have to unmute you. Can you, okay, fine, now you can speak.
No, I have to say it is such a pleasure to listen to Professor Somerville, to Jane speaking about all this wonderful history that we are now actually implementing, or let's say trying to implement. And even more so to hear it from a strong lady when you see that even impossible things can be possible with the right attitude and right teamwork. So this is really wonderful to hear. I was actually thinking what I could ask Professor Somerville, Jane, and you know what many times comes today is her fellows who are called very famously unicorns. So, and they're very proud still of this term unicorn. So maybe you can tell us, how did this name come up? How did you thought about this name? And it's still very much present, the famous Jane Somerville unicorns.
Well, I hope they're famous. They're great. And I was very lucky to have these fellows. I'd just like to say, Margherita, thank you for your kind words. And my name is Jane. Somerville belongs to a man. So please call me that. Well, the unicorns were created by a very favorite and successful fellow, one of the few men, very successful, Horacio Capelli, Argentinian, who became president of something or other, was an excellent pediatric cardiologist. And he chose to come to me under the influence of his teacher, Louis Becou, rather than go to John Kirklin. And I thought that was pretty good of him to do that. I think I'd have gone to John Kirkland, but anyway, rather than come to the UK. And he was one of the best fellows I had. And he went back and did good work in Latin America and in his own country. Argentina was the leading pediatric cardiologist. And he coined the name unicorns. And it came about because I was very critical of my fellows who didn't use their imagination when they were and we had to use our imagination. As John has said, everything was new. So you didn't have a bit of imagination, you might not move on. And I was very critical of my fellows, all who thought they would be good or were good pediatric cardiologists. I hope they would become. But I said, you're not going to come to anything if you don't use what's in your head, your imagination. And I told them the story of that Brock, when he was diagnosing, he used to x-rays, and someone asked him when he diagnosed something exotic, an eosinophilic something or other in a rib, very rare. And they said, but sir, how do you know it's that? He said, I know it's that. He said, I've never seen a unicorn, but if I met one in the street, I would know what it was. And I used to tell that to my fellows. And so they call themselves the unicorn.
Thank you, Jane. I'm reading, we have a very global audience here from the 5 continents, not from the Antarctic yet, but we are working on that. And I don't have a question, but a nice comment I want to read you. Mariela Murasha, She writes, "Thank you very much, Jane, for your immense contribution to the management of GUCH. Warm regards from Buenos Aires." This is, I think, a very nice message. And now, John, back to you for your questions. And Margherita, back to you as well. If you have questions, we are really happy to share your questions with us. John first.
Thank you, Filippo. Jane, I've really enjoyed that discussion about imagination and unicorns, but let's just look to the future now in the same way. We've had so many advances in the treatment of congenital heart disease. So as Filippo said at the beginning, most of our patients born with congenital heart disease now survive to adulthood. What do you think going forward are going to be the big challenges for that population as they become older?
Well, I think the first is the challenge for us to keep track between pediatric cardiology and adult cardiology. And until we share databases, philosophy, and understanding that what goes on even in our genes, I mean, you see it in your own children. We keep track of our children. Goodness knows, both John and I, we know our children, and you have to keep track. And you see things in them that you can't believe as they approach 40 or 50. Mine, John's are younger. But I mean, if we cannot share our databases, we are not going to know what happens, since most surgery and most corrective procedures, not entirely corrective, take place in infancy and childhood. One of the first troubles I got into as a house surgeon was stopping them billing total correction of fallow. And I changed the billing, which of course came from the surgeons, not from me. I changed it to repair of fallows tetralogy, and I was told that was completely wrong not to use the word total correction. Ha ha, I said to myself, very young, not quite understanding what I was saying. But until we know, and I don't know, there is such a split between pediatrics and adult cardiology, not just in congenital heart disease, because the pediatricians really want to hold on to the patients for as long as they possibly can, which is no help whatsoever, shows very badly in the charitable side where they go off, operate on lovely little blue babies, turn them into lovely pink ones, not having any clue once they get pregnant or some arrhythmia or whatever, no provision in the charitable sector once they are no longer pretty little children. And the philosophy is there in pediatrics, and adults don't want to have anything to do with pediatric cardiology. They can't bear the words we use, but we've got to join a database. And we can't do projective, useful research on treatment, on clinical, I don't think, until that's done. That's the first thing we have to do. Then I think we've got to grow valves. We've got to ask the surgeons to grow, a patient's got to grow their own valves somehow. Very good work being done by Magdi and a number of other teams. And I think if you could grow your own valve and then that's put in you, it would last much longer. Then somewhere along the line, I think we've got to research into stopping calcification. It destroys one of the commonest lesions, which is a bicuspid valve, very common in the population. And what happens? It calcifies. It's not just the bicuspid valve, I think. And I think that's something we could help with if we, I don't know. What do you think, John, we should be researching on? Pulmonary hypertension, that's the other thing.
I think these are really important sequelae and the consequences of the treatment we did in childhood. But I'm very gratified by now is the number of people with adult cardiology training who are going into the specialty. Because for me, the patients are now getting older. They're 40, 50, and 60 years of age and developing acquired heart diseases on top of their congenital heart disease. I think it's that combination of the two which is going to shape the future for many of our patients. So I love the idea that this specialty is maturing into something very important as part of adult cardiology, and people who understand those diseases are now paying attention to our patients as well.
I think that's very important. Strangely enough, I mean, they certainly are seeing coronary disease. I was seeing coronary disease in them, but it isn't all that common, is it, John? But they are being studied very young. And if we could have long-term databases, it would be very valuable to your work.
No, I agree. But we do see congenital heart disease driving some of these problems. Coarctation patients almost inevitably
Yes.
up with hypertension. And of course, obesity, that world scourge for heart disease, is going to have a major impact on some of the circulations that we've created, those rather fragile circulations in adults. So I do think this bringing together of congenital and acquired heart disease is going to be very important for our patients going forward.
By the way, I would just like to put in, this is a plug for self, and I don't approve of plugs for self, but the concept of cardiovascular disease will definitely influence the onset of coronary disease, because these coronaries may not be normal, even when they're very young. And coarctation is the perfect example. It is a disease, congenital cardiovascular disease, not just a simple narrowing seen by surgeons.
Well, I said before, Paul Hood was professor at Hammersmith, and when we started with John, his memory was very vivid. But with me and John, there was a third important person, John Cleland. John, welcome to our dialogue. The three of us started at Hammersmith. It was really an exciting time. John, any question for Jane?
Well, it's just lovely to see you, and you look remarkably. I'm just astonished at how well you look, and so
You mean,
congratulations.
for my age, I'm not having it mentioned. Thank you.
No, and I'm certainly not, but it's lovely to see you. I never actually had the pleasure of being your senior registrar, but I was senior registrar to both Celia Oakley and Attilio Mazzari. Celia's sadly departed. But some of the discussions and the debates between you and Celia were famous, or perhaps notorious, across the Hammersmith, across the Hammersmith and Brompton. I just wonder whether you could give us an anecdote because here we have two of the most famous women of British cardiology ever. So
I can't, because I make a rule not to make about my female colleagues. It's always been a rule, but we were friends at a distance and respectful of one another. I was in the heart hospital, not the Brompton. Brompton was the last place I wanted to be. We were the heart hospital people, and Hammersmith was our rival. So, of course, there were plenty of opportunities. And I think Celia, a redhead, I have never been very close to all but one redheads. I've avoided them. So
you have red hair now?
She was red. So I avoided the thing because I knew there was danger, but I was prepared to engage and lock horns if needed. And I think that Celia was a very clever person. She was much cleverer, more knowledgeable than I was. I don't think she was as good at manipulating men, which was perhaps more useful in the business. But I had great respect for Celia. Mm. And when we were together, or, in a conference or something, we were quiet and would discuss life. And she had this terrible loss of a child. And I can understand that, what a terrible thing that was, and that colors you. I also think that I had a much more sensible husband, which was a help to me. And he kind of kept me in order a bit, Walter did, because he was so perfect. And Celia was in charge, and we used to discuss these matters. And my husband always promoted Celia above and beyond what was necessary, I think to partly annoy me, but anyway, it did. He was right, but he was a much wiser man and cleverer man, wouldn't you think, John? Celia,
I don't know. He was excellent at cardiac ultrasound, so it was.
Yes, he was very good.
Yeah. So yeah, I just think I think you and Celia were probably the best two clinicians in London when I was a senior registrar. So
Well, thank
I
you very
think
much. Thank you. That's a great compliment.
Thank you, John and Jane, for discussing Celia and her incredible past. Again, a pity we cannot have a dialogue with her, but it's really worth mentioning today her remarkable contribution to cardiology. I've been working with her, with John, with the two John here for some years, and I think all of us, we were fascinated by her knowledge of cardiology, her ability to make a diagnosis based on her brain, not AI, not artificial intelligence, which these days is so fashionable, but really medicine based on listening to patients and examining patients, even without ultrasounds, without angiography. Really, the medicine we should teach our younger trainees also in these days.
But I
Now,
think this is where Jane and Celia had something in common, which was sort of logical deduction, that if you have X and Y, it must equal Z.
Sherlock Holmes approach.
Yeah.
Now, this dialogue is really very, very English. I see in the audience another distinguished English cardiology, Richard Sutton. Richard, are you with us? Are you there?
Yes.
Hi. Yeah, I've read your beautiful question, but perhaps a comment. But perhaps you can tell us directly.
Well, I was senior registrar to Jane in the 1970s, mainly I think 74, and it was a fantastic experience, because I think Jane was to me as Paul Wood was to her. I recognized how important clinical diagnosis was and clinical analysis. And although I failed to become a pediatric cardiologist of any sort, I kept all of those things she had taught me all through my career. Another thing she taught me was that women in cardiology are very good. And they don't need encouragement anymore because they've arrived. And they don't need much protection either, because having been head of training in Northwest London for 15 years, I saw a lot of applicants for cardiology. The good ones were women. And fortunately, we now have a lot. Probably we need more. So all of that is down to Jane in many ways. Thank you, Jane.
Well,
nice. It's so sweet. Thank you, Richard. Really, I didn't know you had these feelings, and I'm delighted to see you again. You were a great senior registrar, and I always thought I learned more from you than you from me. But anyway, I'm delighted to see you and hear what you have to say. Thank you very much. Great.
But also let me read the last part of his message, Richard's message. The last sentence is, fortunately, women require much less protection these days as they exceed the men in so many ways. I think is an important statement. Okay, now, last remark. John, Margherita, and John again. The two John and Margherita. Any last remark, comment, question for Jane?
I had a last question. We've talked for a lot about colleagues and figures in cardiology from the medical side, but one of the things about adult congenital heart disease that I love is the long-term engagement with the patients. And I'm sure Jane will agree with that, but the patients are the things that keep us going. Tell us about a person that you looked after, a patient that really changed your thinking and changed your views on medicine. You've created a GUCH association, now the Somerville Foundation, where all the patients with congenital heart disease are together. This has been a huge influence, hasn't it?
Oh, yes. It's the patients that matter. It's the patients that you've got to see. It's the patients that you've got to touch and become their friend, but at a distance. And I think without that, I would not have enjoyed medicine. I mean, I think you ask about a patient. I think about uh, Judith, born with an AV canal, no syndrome, in Great Ormond Street. And I remember seeing her as a baby. I remember tracing her, and she recently has died at the age of 63. And a number of things she has taught me about. We went through the difficulties of her having a pregnancy and failing. We went through several outside operations, the awful scar the surgeon made in the wrong place when he banded her pulmonary artery, wrecking her left breast. All these are issues that have to be dealt with, these long survivors. Pacemakers, terrible arrhythmias. Fortunately, we've got very good rhythm now. All these things, and in the end, the heart fails. And one of the most impressive parts of grown-up congenital heart disease is the courage of these patients. I mean, if someone said they were going to operate on my left foot, I'd be away. I wouldn't have my left foot operated on. They go through hell, suffering. They're up for anything, the latest machine. They want to have transplantation. And one of the things of the future of, and Judith wanted transplantation, but she was untransplantable, I think because of odd antibodies or something that I didn't understand. But something had happened in her earlier activities. These are what the GUCH doctors are going to have to protect from, because these patients want everything if possible, and they have a courage that is beyond admiration. There's a new word for it. And I have been constantly impressed by this. And it really buoys you on to do things, to do what you believe in, because the patients have this strong will and strong courage and up for it ideals. I think John may be able to express it better than I can, but it has moved me constantly. And even now, I think about the loss of this girl, age 63. So I knew her 63 years. And I still feel that sort of pain, but it buoys you on to do better. And I wonder, does John feel the same? Because they're the same group of patients, just not so old, because he's not so old. What do you feel, John?
Well, for me, this has been one of the joys of medicine. I tell my fellows and trainees that this is one of the few areas of medicine when you grow old with your patients and you look after them not just for a short period in later life or for a period in childhood, but you look after people throughout their lives. And the joy is when they come back with their own children and you look after people for decades. And I, like you, have patients like that who've inspired me and actually changed my views on clinical care and changed my attitude to how people should be looked after. And it is that personal relationship which is wonderful in clinical medicine. And you taught me that at the beginning, which is why I went into treating patients with congenital heart disease. So I have to give you my personal thanks as well.
Thank you both of you for your incredible enthusiasm, which is really contagious. Very last remarks, Margherita and then John.
Thank you. Well, I can only truly congratulate to Jane, to John, and to yourself, Filippo, on a really wonderful congenital heart disease dialogue. So it was a pleasure to listen to all of you. So thank you very much.
Thank you, Margherita. John, very last remark.
Which John?
No, well,
So
John,
I'm just
before.
impressed that Jane seems to be just so current on the ball, and I just see no let up. That's the intellect and the forward thinking is still there. It's amazing to see the retrospective, but also it doesn't end here. It looks forward as well.
Thank you. And I have a very, very last short question. I ask all our guests. How can we first thank you for joining us for this dialogue? Suggestions how we can improve our dialogues, Jane? What can we do better?
Honestly, I'd have to see the result of this epic before I could make a comment, because that's what makes me feel. And I don't think I know enough about dialogues. What I do think it is a wonderful idea to connect and communicate, which is what we all want. And it does have benefit besides knowing each other's politics. I think it has great benefit in medicine. And I'd like to just make a comment that is worrying me as I leave the planet. It's going to happen soon, I'm sure. But anyway, I do think it's really awful that doctors, consultant doctors, where the buck stops, think they can conduct medicine, certainly in grown-up congenital heart disease or any medicine, over the telephone all the time. You have got to see patients, you in congenital heart disease. So don't obviate those skills. They are extremely important, and they're extremely important. It's like having a child and never touching it.
Thank you, Jane. I can give you a first matrix. This dialogue has already been seen by 900 colleagues on X, and the number will grow in the next few days. So it's already remarkably successful. Well, thank you, Jane. Thank you, Johns, both of you. Thank you, Margarita, and Richard for joining us for this dialogue. It's been a wonderful hour. I've learned a lot. And again, thank you for your enthusiasm, which is really contagious. I remind you that our next dialogue will be on the 27th of February at 5 o'clock Central European Time. Please join us. It will be another fantastic dialogue. Thank you very much. Bye-bye.